distracted y'all want to be with my lesson, right? Y'all want to distract me enough and not just have me up here harping the whole time for 2 hours?
Hey, you have to pick a date for that test too.
I'm going to. Jets. Jets. All right. So we talked about shoulder arthrograms last time. Now we're going to talk about knee arthrograms and detail on. Huh? I did send these to y'all. They're in your email now. They're all divided up though per section. So it's like 5 or so PowerPoints.
So they're not really big.
So all we have to give them fit in the email.
Oh.
They're very large. Okay, so when we do knee arthrograms, we're going to focus on what's called the vertical ray method, which looks like this torture device up here with the gloved hand. That's our vertical ray method arthrogram, considered the ideal optimized way to get these exams done. And they're going to use what we call a stress device. What's a stress device? That's that torture machine you see right there. That lengthens and straightens out the leg to further separate that joint space so we can fill up that joint space with contrast and get the best overall look at those menisci and the synovial joint space. We're going to fill it with that contrast. Because why do we do arthrograms? To check the integrity of those joint spaces and those ever important joints of the knee, shoulder, wrist, and only those, right?
Huh?
Only shoulder, knee, and wrist? Correct. Any joint. Any joint is technically allowable for arthrograms. So we will put this limb and stress device after contrast administration. It's to widen that joint out. What kind of images will we do as plain films? We'll do just a plain AP knee. And we'll do an AP oblique where we're going to rotate that leg 20 degrees to the right and to the left. And it's going to help coat that entire synovial joint capsule and give us that nice, beautiful view of that knee joint. And along with that stress device, often the doctor will pull the leg, like you're seeing right here, just to further separate that joint space and give that best overall look of that synovial capsule found in the knee. So here's some anatomy we need to review. We looked at this a little bit in Rad Pro 2. If you remember way back a year ago, I said, don't worry about memorizing this now, but put it in the parking lot till later. Well, we're taking it out of the parking lot and we're going to look at it now. So these are some of those very important ligaments and tissues found in the knee, surround that joint space that they're often going to evaluate using these arthrograms. Now, along with arthrograms, usually with the knee, they don't do MRIs to check these tissues. But depending on how much money or insurance that patient has, they may only rely on the arthrogram to evaluate that knee and any kind of tears going on. So, if we're looking at this knee here, fibula is on what side of the knee, by the way? Lateral side. So we have the lateral meniscus and the medial meniscus. We have the LCL, the ACL, the PCL, and the MCL. Does anybody know what those stand for?
ACL.
Anterior cruciate ligament.
Anterior cruciate ligament. So what do the other ones stand for?
Posterior cruciate.
Posterior cruciate,
Also
lateral cruciate,
And then medial.
medial cruciate. Know how to label those. That's some tissues that we're going to evaluate while we're doing those arthrograms. Over here, we're looking at a side view, sagittal slice of the knee. There's your patella, there's your superimposed condyles of the femur, and here's that joint cavity that we're going to look at. If you've done these in clinic, you may notice that when they're filling up that joint capsule, it makes that J shape, just like this.
What's up?
Huh?
I said, yeah, what's up?
Yeah, what's up?
Like a J or whatever.
Oh,
J for J.
good Lord. Okay. That's going to be that whole synovial joint space that we're evaluating that you see in purple here. That's the area of interest. But we also have what's called the articular cartilage. We also evaluate that. Why do you think we evaluate that articular cartilage? To see if it's gone, to see if it's eroded, because if it is eroded, what's going to happen? Bones are going to be grinding against bones, and that's going to be very, very painful. Then we have the medial meniscus here. That's also adding to that padding area. We want to make sure that's still intact. And then, of course, we have that's just more of the synovial joint cavity back here. It goes between the knees all the way up towards that upper portion of the femur as well. These bursas, don't really worry about those. Don't worry about your tendons like the quadriceps or these muscles. I want you to focus on the cruciate ligaments and your synovial joint capsules and your menisci. That's the main points of interest on those.
Is the meniscus a ligament or is it a...
They're padding. They're padding. More padding to
And
help.
it can tear. Meniscus can tear.
Yes, they can. They can rupture as well.
If you fall or something.
Yes.
So the only thing that's holding the patella in place is that leg movement.
Yes.
So if
That's why it's easy to dislocate your patella. Yeah, if you hit your patella the right way, I mean, it can be knocked up here, it can be knocked over here, it can be knocked to the side. You never seen that before?
Super uncomfy.
Well, actually, now that you say that, I think I have, but.
Yeah, it's held by, well, really it's two ligaments. You have the ligament, you got the tendon up here, you got the bursa ligaments down here as well, holding it in place. But it's very easy to dislodge, to answer your question. Yes, very painful as well.
You have a lot of freedom of motion. You can actually move it along.
I mean, yeah.
You can just
I
pop it
know.
out of the socket right now if you want to. Just,
You can.
Right.
all right, so that's just showing you what those plain films would look like, guys. If we're looking at this very close, there's your femur, there's your tibia, here's the joint space we're evaluating, and that's what the meniscus would look like on an x-ray. Actually very hard to see. This would not be what we consider an optimal way of looking at these areas because CT and MRI is just going to be superior in every way at evaluating the knee joint space and, of course, tendons and ligaments. All right, so for knee arthrography, we will use double contrast. Double contrast is going to, of course, be composed of the contrast and air in combination. It's the only way we can really see that joint space very well. So to demonstrate the medial meniscus, we're going to have the patient lie semi-prone with the medial meniscus up. Reason being, we actually want the fluid of the meniscus and the joint capsule to fall down to give us a better overall visualization of the meniscus with just air, essentially, just air. So we're going to put that up in the air. The area of interest will be up in the air. We'll widen the joint space with manual stress and using that device you saw on that first slide. CR will be centered to the medial side of the knee on the meniscus for the first exposure, and then we'll make 5 subsequent exposures, rotating the limb towards supine 30 degrees for each exposure. Basically, they're just going to check that joint and that meniscus at different angles as you move that leg back and forth. Also, it's going to coat that joint space as well with more contrast, giving you that overall better series of pictures. They don't really ever do these much anymore, by the way. If you do these in clinic, really all they're going to do is just inject that contrast. The doctor's just going to take pictures with the fluoro machine. You're not going to do these plain films like we're learning about right here. Very, very rare. Have they made y'all do plain films on arthrograms? I doubt it, right? I didn't think so. All right, to demonstrate the lateral meniscus, well, once again, area of interest will be elevated. We'll put the patient semi-prone, lateral meniscus facing up. We'll also widen that joint space and essentially do the exact same thing for that lateral meniscus. 6 exposures for lateral, by the way, 5 for medial, 6 for lateral. Reason being the lateral is slightly larger than the medial. So first exposure will be the initial prone oblique, then we'll rotate that limb 30 degrees towards the supine position for each exposure, just getting different visualizations of that joint space in that meniscus isolated. So done the exact same way, we're just adding 1 extra exposure for our lateral meniscus. That's kind of what it looks like right there.
So they're in a prone position and then they're going to semi-supine?
Yes, yes. So, wait, where did I have semi-supine? Semi-prone.
I mean, but like
Yeah,
you're rotating the limb
right there in the
30 degrees.
second bullet on the top. You should-
Semi-prone.
And then you have.
So yeah, you're gonna rotate it not all the way supine, but towards supine. So you're just twisting the leg. Obviously, you can't twist the leg all the way supine, but you're twisting it towards the supine position. What's that saying? They will stay prone the whole time. We're just twisting the leg to make it more supine. And as you twist it, it actually opens that joint up more and more.
And how do you do 6 exposures on one arm?
I actually am not sure about that. I was reading that in the notes today when I was studying this, and that is a really good question. I am not sure, but that's what the Merrill's book says. I feel like that'd be a mess because you wouldn't really be able to see anything. It's on one IR, but I'm gonna have to find out more about that. I'm curious too. I don't know if that's a typo, but the book has it too. The book, it's in the book. I'm not sure about that. But that's what the curriculum says. All right, so now we're just going to go to hip arthrograms to wrap up arthrography. So why do we do hip arthrograms? To evaluate congenital hip displacement in children. That's a big reason we do those. Detecting a loose hip prosthesis in adults has actually come out of socket quite easily, a lot more than you realize. And to confirm infection of the joint space in the hip. That hip joint space is actually very prone to infections, which is why it freezes up on a lot of elderly patients. Common puncture site will be in the inguinal crease, lateral to the palpated femoral pulse. We're going to fill up that area where the acetabulum is located. And usually they'll use a spinal needle to reach that specific joint capsule, a little bit of a deeper injection spot compared to the knee and the shoulder. So as far as anatomy goes in this section, guys, obviously what I want you to really focus on is you're going to see those synovial joint capsules very well with the contrast, but all that anatomy we learned from Rad Pro 2 on your shoulder, your knee, and your hip, that's all going to come back into play as well. Does that make sense? All that area that we've talked about, trochanters, the tuberosities, the joint spaces, so on and so forth. So make sure you're tightening up on your anatomy with those.
I have a question.
Yeah.
Is that a pediatric patient?
Which one?
Both of them?
They are, yes. How do you know that?
Because of, they're not fused together?
Correct. You see the obturator foramen is not fused, the rami are not together.
They do that on
Absolutely right.
pediatrics?
That's a young kid. Yeah, they do this a lot on pediatrics because they have a lot of congenital hip displacement diseases. Yes. Very common pediatric exam.
I got a question too. Like, these type of exams, do they check for abuse on kids too, or they can't really see?
This one not in particular. Usually they'll check that prior.
Okay.
Really what they're checking is like an actual deformity in
Okay.
kids.
Does this confirm infection in adults?
Yes, because adults get a lot of infections in the hip joint, especially as they get older. Why? I don't know why, I just know it's very common. All right, and of course, other joints. Once again, any of the other joints can be evaluated by arthrograms. We're not going to focus on those too much. The main ones I want you to focus on being the shoulder, knee, and the hip. But keep in mind, any joint can be evaluated under fluoroscopy using those arthrography injections. This, of course, would be what? Good Lord, only one person knows is a wrist.
It's a wrist.
Okay, I hope y'all know it's a wrist. Yes. Okay.
Okay.
So
It's not an
brush
ankle?
up on your
Simmer.
purple bones. Hint, hint. You may or may not see that on your test. I'm just saying. I just got a feeling.
Should make left the part to dry clean or
We
whatever.
don't have nothing. But hey, you got the.
Still remember. There you go.
Is there gonna be an image like this where it's filled with contrast?
It would be a contrast image, yes.
It's so hard to see.
Look at you.
But if you look closer, you can still make out the little borders pretty easily. I sent that to y'all as some practice as well. Okay, which forms of contrast may be used for arthrograms? It's gonna be a combination of both, radiopaque and radiolucent. What would be the radiopaque contrast? Not barium, but the iodine-based contrast. Please don't inject barium. That's gonna be a bad time.
That's what we're using.
You're gonna be trying to push that syringe, you're like, "Ugh, won't go in." And what would be radiopaque contrast?
That is radiopaque.
I'm sorry, radiolucent. Radiolucent.
Air.
Air, correct. So a combination of both. That would equal a double contrast study. That should be C, I'm sorry. That means the same thing, all the above. So, combination of radiopaque and radiolucent. Okay, which joint is most commonly imaged via arthrograms? What's the most common one we do?
Shoulder.
The shoulder, correct, correct. Most common area that we have those tears with those ligaments. Second most popular would be your knee, followed by the hip being the third most common. Okay, so now we're going to go to liver and biliary. See, arthrograms, it wasn't too bad. Not too much new info. Liver and biliary mostly should be reviewed because we talked about that way back on the first PowerPoint of this semester, where we labeled that biliary tree. So guess what? I still want you to be able to label the biliary tree and the gallbladder. So if you were having some issues with that, we're going to briefly review that going forward. And we're going to talk about the actual procedures that we do when it comes to biliary tract. These are actually interesting to watch. I like watching these in clinic, especially that last one, ERCP. We used to do a bunch of those at TCH, and it's very fascinating to watch. We're going to talk about a percutaneous transhepatic cholangiography, post-operative T-tube cholangiogram, which is probably the second most common one that they do, and the endoscopic retrograde cholangiopancreatography. That's a much easier to say, ERCP.
You just ain't gonna get it.
So make sure on your test you write out endoscopic, retrograde, cholangiopancreatography. The whole word.
Right there,
The whole word.
That's a test question right there.
Yes.
What was the
That's-
answer?
Gold star.
Hmm?
The answer to the second
Shoulder.
question. I'm gonna go to clinic
So
and
what
ask
we're-
the text with them. With the.
You should, see if they remember what it is.
Probably don't.
The, what we're looking at here is actually a T-tube. Does anybody know how I know this is a T-tube, aside from its label as a T-tube? How do I know this is a T-tube exam?
Because of the shape?
It actually makes the shape of a T right
Yeah.
here.
Oh,
Can you look
okay.
closely?
Oh.
It's actually in the shape of a T. It's a T-tube cholangiogram. But everything else should look pretty familiar. There's that common hepatic duct. There's the right, there's the left. What was around right here, guys? The common bile duct. We have the gallbladder is not showing up on this image. The gallbladder's about right here. What does the gallbladder connect with? How does the gallbladder connect to the bile duct via the cystic duct? And there you go, in case you forgot, guys. There's that very important hepatic tree. Bless you.
Thank you.
Just remember, start from the gallbladder. We have the fundus of the gallbladder down here. We have the cystic duct, which connects to the common bile duct. If you move more superior, you have the common hepatic duct. Then your right and left hepatic ducts that branch into that actual tree that we see on those exams. Which one? The hepatic duct's right here. I'm sorry, common hepatic's right here. It just says hepatic is common. Here's the right and the left branching off. Of course, your pancreatic duct here, that all dumps into the duodenum. Does anybody remember what that funny word was there that dumps into the? Good, ampulla vader. Ampulla vader, very good. Correct. Ampulla of Darth Vader, that's right. Okay, so percutaneous transhepatic cholangiogram. These words are so long. Percutaneous transhepatic cholangiogram, abbreviated PTC, thank God. Why do we do this? It's primarily for patients with jaundice. And what is jaundice exactly? Y'all should know what that is. It's an issue with the liver whenever you get very yellow. Have y'all seen any jaundiced patients out there? They actually do look yellow. So when a patient has jaundice and we know that the ductal system is being affected, we will have that demonstrated by CT or sono, but often that's unclear, so they're going to go ahead and do this exam to further examine that area to see what's going on, see how that area of the body is malfunctioning, so to speak. So they'll also usually put a drainage catheter to treat what they call obstructive jaundice. Some of that infection you can actually drain out via that catheter. And that's what it looks like right there. There's the tiny little catheter going directly into that hepatic tree. That's the right hepatic duct. That's the left hepatic duct joined together to the common hepatic duct that you see right here. Looks a mess, but that's in general what we're looking at. As we go down, there'll be your common bile duct. Cystic duct about right here. Gallbladder is a little bit difficult to visualize. But that'll be what your PTC exam looks like. They don't do these much anymore. They mostly are going to do the T-tubes or the ERCPs. But if they were doing this, patient will be supine, right side, surgically prepared and draped. Why is it the right side? What side's your liver and gallbladder on?
The right side.
Right side, just make sure you know what side it's on. They will use a local anesthetic. They will not put you completely under for these. You're usually just sedated. They'll use a special skinny needle called a Chiba needle. That's the Chiba needle. It's itty bitty. And they'll use a water-soluble iodinated contrast under fluoro. After they fill up that ductal system, like you see right here, they're just going to do spot AP projections. Like I said, they don't do these much anymore. This is pretty obsolete. The next two, they do still readily perform a lot, especially on pediatrics. Those are staples, it's surgical staples. They've been opened up before, likely to try to repair the biliary system. I got cut up down here too. Now we're going to talk about the post-operative T-tube. By the way, what does post-operative mean? After surgery, so post-operative T-tube cholangiogram, also called delayed cholangiography and T-tube cholangiography. Goes by all the names. We'll use an actual T-shaped tube, like I showed you on that first picture. It'll be placed in the common hepatic and the common bile duct, respectively, for post-operative drainage. So after they've done a surgery, like on the gallbladder or hepatic tree, It's very common for drainage to build up in that area. So they'll do these T-tube cholangiograms to drain the extra fluid out to help prevent further infection in that specific area of the body.
So they do another surgery after surgery, or they just put
They
the
do
tube
a,
in
they do a
there?
procedure after surgery.
And
That's why it's
just-
post-operative.
So they insert the tube, correct?
They do.
So it's not really, well, it is a surgery still, alright.
It is. It can be done in a fluoro room, by the way. They can do these in a fluoro room.
Cause I've had teeth for drainage, I didn't know when they did that.
You had this exam?
And it, but.
You had this
No,
exam?
not this one, but I'm just saying I've had tubing put in for drainage, right, after surgery. But I didn't know if that was done like right after, or is this something that's done exactly after the surgery, or like,
Pretty-
they
I
wait,
mean,
like
not
you
in-
have the surgery and
Not
then like a day?
immediately, but pretty shortly after. I mean,
Okay, that makes sense.
that drain, that fluid will build up really quickly and get
Yeah.
infected, so they move pretty fast on those. So perform to demonstrate caliber and patency of the ducts, status of that sphincter of the hepatopancreatic ampulla, in the presence of any more residual or undetected stones in that gallbladder. And what are gallstones called? Cololiths. What are kidney stones called? Renal calculi. So make sure you know the difference. Everyone always mixes those up. Cololiths. And look, it's in the word, cola. Not Coca-Cola.
I was just gonna say.
C-H-O-L. C-H-O-L refers to gallbladder biliary system. If Coca-Cola helps you, go for it. Okay, so it will be performed in the radiology department, just under normal fluoro. Preliminary prep will be, the tube will be clamped the day before the procedure. The tube will be filled with bile to prevent air bubbles. Preceding meal withheld. Cleansing enema 1 hour before procedure if needed to clear up that area. And a preliminary KUB will be obtained, that T-tube cholangiogram. It looks just like this. Same picture we looked at before. There's your T-tube that's been inserted surgically. It's already gonna be in there. They're actually just gonna inject the contrast in the fluoro room through that already inserted T-tube with that patient under light sedation. Yes?
Is there anything that like stays out? You know, like a.
The tube,
like-
just a
yeah,
tube.
Does it have like a bag or something?
It does, for drainage. Yes, it does. Like that nasty old bile. Bile's pretty gross.
So they put the tube in to inject contrast, to look at the biliary.
And for drainage,
And for drainage.
dual purpose.
And then they took out the tube?
If,
Once they
well,
look
once
at it?
once they're able to, like if they're still having a buildup of fluid and issues, they're gonna keep it in until they can confirm there's no more fluid buildup. So they're gonna monitor that patient for a few days to see if it reaccumulates. If it doesn't, they can remove that tube.
So stuff comes out and stuff goes in. On the same tube.
Yes.
So does
Well,
it
only thing
get
you're gonna put in there is contrast. Everything else needs to come out, and really they'll pump the contrast back out as well.
Oh.
Now, here's a great question, just for
It's a
fun
little
thoughts
sus.
here. It's a little sus. Okay,
Yeah, 'cause
Ariel.
stuff's coming in and out, isn't that like the weedy little
Well, contrast is
birdies behind?
not with contrast, not really.
Well, you
Now,
should-
here's a great fun
Thank
question.
you.
Look at the shape of this thing. It is a T shape. How do you think they get that in there?
It
'Cause you
goes
can't really
in like
put
an
it in
arrow.
there. Like that.
this and then out.
You're actually absolutely correct.
Mhm.
So, if you can demonstrate that again, Jay.
It's,
They put
it's
it
like
in
an arrow. So you
straight,
go in
and then they
then
extend it once it's in the actual bile duct.
That looks like an IUD.
Yeah, I was gonna say, like, alright, so they probably do everything.
Mhm.
Yeah, that's how they do it.
And of course, when you're ready to take it out, they just retract it and it folds back up. It folds back up when they're pulling it out. Hopefully they don't pull it out like that, they'll just rip the whole tree out, which would be very painful, but pretty cool stuff to watch. These exams, like I said, are very interesting to watch at the hospital. I always liked being in on these. Okay, so after the KUB has been obtained, the patient will be put in an RPO. Why would we put them in an RPO? With the right upper quadrant centered. Why not an LPO?
Oh, because you want to see the left stuff.
It's gonna, where it is the biliary tree in the gallbladder. Right side, it's a little more posterior. I wanna put it closer to the IR to separate it from anything else that's gonna superimpose on as well. Get that nice, beautiful look at it. Contrast media will be injected into the T-tube under fluoro, and they'll make those spot films as needed with the fluoro tower. You're usually not gonna do plain films aside from that one KUB. These are always done by Dr. Fishhead. I call him Dr. Fishhead. He was very good at what he does, but a very arrogant man. So either call him Fishhead or Fishface. He's like very in love with himself, but very talented at the same time. Quite a dichotomy. He did a lot of these on kids. But the ones he did the most are actually this next one that we call the ERCP, which those are really cool to watch. Here we go, ERCP, very cool exam. If you've never seen one of these, they often do them at pediatric facilities. What's really neat about these is you're doing a combination of the fluoro with the endoscope. And if you ever saw an endoscope procedure, that's a camera that goes inside the patient. You can actually see inside of the gallbladder, the biliary tract, and so on. It's very, very cool to watch. So, why do we do these? To diagnose biliary and key word here, that's why it's in the name, pancreatic pathologic conditions. So, useful method when the ducts are not dilated and the ampulla is not obstructed. We'll use a fiber optic endoscope through the mouth, by the way, into the duodenum under fluoroscopy. Now think about that. Why do we put a fiber optic scope through the mouth and then into the duodenum? Because aren't we trying to get to the gallbladder and the biliary tree?
Isn't it just like a shoulder way in?
It's not a trick question, so I'll make sure you know your anatomy.
You can exit or enter the gallbladder through the ampular vader, right?
Well, not the gallbladder, but you can get to the biliary tract through the ampulla vader. So think about it. Is there any other way to access that biliary tree aside from the duodenum? No. We have to go through the mouth and essentially go backwards. So we're going to go down the throat, through the stomach, into the duodenum. Duodenum is where all that bile dumps through the ampulla vader, so they will enter the ampulla and then trace it up the tree towards the gallbladder. So it's like almost like they're going through a maze to try to find it. That's why it's really cool to watch them do these, because you get to watch this camera the whole time go down the throat, into the stomach, through the duodenum. You find that little tiny ampulla. It's a very, very itty bitty little opening. They get through there and then trace it up till they see that cystic duct and go directly into the gallbladder. Pretty fascinating stuff.
So for this one, they are asleep.
They are only sedated. They're not asleep. And that's probably the only part that's a little hard because they're kind of gagging the whole time. The whole time. But they don't know what's going on because they're giving them the forget drug. So I always think these look like as well. The way you can tell the difference between these two exams. T-tube, easy to see, it looks like a T. ERCP looks like they have a snake inside of them. That's the camera. That's the camera that they're using to get into the biliary tract. That's what it looks like right there with that illustration. Doctor's going to be looking down this thing. You're going to have it up on a TV screen as well. You're going to trace that all the way down into the stomach, to the duodenum, enter that ampulla vader, and then trace it towards the gallbladder. So they'll actually put a local anesthetic in the throat to hopefully not hurt the throat too bad, because they are awake, just heavily sedated during this exam. You can't put them to sleep on it. I don't know why that is, but they just heavily sedate them. But they don't remember what's going on. They give them the forget-me-not drug. That's a real drug, by the way, the forget drug. I just forget the name of it.
Fentanyl.
That's it, thank you. It can make you forget everything that you experienced.
Wait, you said you forget the name of it?
Yeah.
Are you okay?
They must have given you the drug initially, yeah. So the hepatopancreatic ampulla will be cannulated, and that's usually what your images will look like right there. See how it looks like a snake? So this endoscope has gone through the throat, into the stomach. We're in the duodenum about this point, and he'll stop right here before the duodenum starts going down, and he'll get a smaller camera that will find that ampulla, and it'll look like a little tiny wire that will trace all the way up here, and usually that camera will go inside that cystic duct right here, and they'll be able to look inside the gallbladder.
It's
They can go-
amazing how small they are.
It's
Yeah,
tiny,
yeah,
it's
they're
super
like
tiny, but it's
tiny.
like a super HD camera, like super
They're really
clear
nice.
resolution. It's really neat to watch.
I have a question. Do they reuse it or they just go every after every case?
Those I'm sure they reuse, because that's like probably hundreds upon hundreds of thousands of dollars for each of those. So contrast will be injected. They'll usually take fluoro images alongside having that camera looking inside internally. Spot and conventional images, but like I said, usually that's just all going to be taken by the doctor using that fluoro save feature. Usually they get that, they call that the gold star shot right there, where you have the snake in the tree. I call it the snake in the tree. Your endoscope and your whole biliary tree filled up with that contrast. So usually you'll actually do these with a C-arm. typically. At least where I worked, they had specialized rooms for these, and we'd bring the C-arm in there while he had his endoscope going and kind of go in and out as he needed us to take those fluoro images.
So you're saying that there's another tube attached to that tip?
So yeah, that's what's really crazy. So you have the main camera right here. Once you get to this point, you stop, and they have another camera that they feed in here with a wire, because this is a very small area. This would, of course, bust through it. So they have to trace that little wire into the ampulla, and that little camera is going to go all the way up in here.
And
Yeah.
this is stitched up?
Mm-hmm. And usually what you're seeing is this most of the time. That's actually the ampulla veda right there. See, there's the smaller camera that he's put into the ampulla once he opened it up. So this is the very end of this endoscope right here. He's going to trace this tiny wire into that ampulla. This is another tube that's going down with the camera to hold that open, to hold that ampulla open so he can feed it into it right there. Okay, so it's really cool stuff. I always get excited talking about those. They're always really neat to watch. Okay, and here's just a couple more practice images, guys, of ERCPs. Here's your camera once again in the duodenum. Here is the biliary tract. Here's the common bile duct. Here's your cystic duct. There's your gallbladder hanging off. Still going up. There's your common hepatic. And then your right and your left hepatic branching off on each side. Same thing over here. There's your endoscope stopping in the duodenum. Actually, your camera goes up the common bile duct, cystic duct, gallbladder, common hepatic, and then it branches to the right and the left at the very top. You can also see that main pancreatic duct as well, going horizontally. Main ones I want you to focus on, though, of course, is that main biliary tree with the gallbladder coming up the right side over here. Excuse me. So keep in mind, guys, once again, when it comes to biliary trees, they're not always going to look exactly the same or as pretty. Every patient, they look very unique, kind of like every tree is unique. The branches all look differently. Same thing with the hepatic trees. I'm left in this front row nodding off over here. Y'all are like literally doing the nod off. Both of y'all over there. You okay?
Is it break?
Well, let's talk about reproductive system. That'll wake you up. All right. It's a break time first.
Dang, you still don't wait.
I know.
Let's take a quick break. Wake up, because this is actually very important stuff.
They ain't